This is Sunday, March the 4th, 1973, and we are embarking on the first of a series of historic interviews primarily concerned with preserving the thoughts and voices of those cardiac surgical pioneers that are still here while we still have the opportunity, period. I am W. Gerald Rayner, and Marv Pomerantz and Ted Sadler and I have the distinct honor of interviewing today Dr. Henry Swan. Dr. Henry Swan is one of the pioneers in heart surgery in the Denver area and nationally and internationally. It is our thought that while we still have the opportunity to interview some of the people who started heart surgery, who worked out some of the most difficult problems, and who set the groundwork for routines that we now take for granted, that it would be of great value to save these for posterity. We will try to make this as informal as possible and to try to make it as interesting from the standpoint of personal experience. Dr. Pomerantz, Dr. Sadler, and I will feel free to interrupt from time to time to ask questions, but for the most part, this is Dr. Swan's day. Dr. Henry Swan was born May 1913, had his early education in Williams and Harvard, and was among the first group of married interns at the Peterbilt Brigham Hospital. From there, after an internship and residency, he went into World War II in the European theater, and from then on got into the fields which eventually led him to the early days of cardiac surgery. Dr. Swan. Dr. Swan, if you could begin by elaborating some on the background of the World War II days that led you into the field that you are now, we'd be appreciative.
Thank you, Dr. Rayner. I think it should be emphasized, as far as my training was concerned, that the training at the Brigham Hospital was associated in a joint venture between the Brigham and the Boston Children's, and that actually during the 3 years that I was in service there, almost 2 years were spent at Children's Hospital, and at the end of that experience, the Harvard unit had already been called out, and I was the only surgical resident at the Boston Children's Hospital for about a period of 8 months, so that I had the private general surgical service, the teaching surgical service, and the neurosurgical service. And as a result of that, I had a rather extraordinary operative experience in pediatric surgery, and this was influential in my subsequent career. I was also there at the time when Dr. Robert Gross was developing the operation for patent ductus arteriosus, so that I had a heavy influence of the earliest days of the surgery of congenital heart disease. After leaving the Boston Children's, I became a member of a surgical team in the 4th Auxiliary Surgical Group, and later in the 5th Surgical Group in the European Theater, and my experience extended from D+1 on Utah Beach to the Elk River. We were in mobile platoons of field hospitals operating non-transportable wounded, and I had a rather extensive experience in traumatic surgery, which stood me in good stead in later years. And among other incidents, I had an opportunity to operate on a man who had a fragment of a booby trap which had pierced his popliteal artery and had cut it about halfway through. And the SOP, or the standard operating procedure officially required, would have been to ligate the artery. But I felt that if I had been that man, I would like to have had someone try to save that artery, as the probability of my losing my foot would have been very great. So using some French-eyed needles, which I had smuggled from Children's Hospital, and some 4 silk, I did a suture anastomosis of the artery. Unfortunately, both for me and for the soldier, the anastomosis worked. No clot occurred, and he left the hospital with a pink foot. So that this experience reinforced my Children's Hospital cardiac experience So when I came back after the war to Denver, I was interested both in the field of congenital heart disease and in vascular surgery. So I entered, I decided to limit myself to pediatric surgery. And was just starting to do that when at the medical school, a new dean had taken the reins of the University of Colorado School of Medicine and had decided to introduce full-time teaching personnel to enlarge the mission of the school, which up to that time had been manned entirely by volunteer faculty. And so, for some reason or other, he asked me to join the faculty full-time, which I did, since it was agreed that I would have the opportunity to have as my domain all of the pediatric surgery. You might be interested to know that my salary as an assistant professor, as the first full-time member of the faculty in 1946, was $5,200. So that's the way I got started at the University of Colorado and the origin of my interest in vascular surgery.
Could you lead us into the development of your interest in cardiac surgery at the University of Colorado and the development of your department?
Well, I thought the most important thing, Dr. Pomerantz, was the establishment of a research laboratory in the Department of Surgery. So my very first effort then was to try and find some space within the geographical confines of the hospital and the medical school. And incidentally, Colorado, the hospital and the medical school are a continuous building, a very fortunate geographic arrangement in medical education. So we borrowed some space from the pathology department, and I was able to get one of the first grants from what was then the U.S. Public Health Service to study the possibility of a shunt between the auricles in the treatment of mitral stenosis. This grant was in the amount of $3,600 and was the first research grant ever existing in the Department of Surgery. Up to that time, there had never been an article published in a responsible surgical journal which bore the byline from the Department of Surgery at the University of Colorado. And so I thought part of my job as a full-time, as the first full-time member of the faculty, was to develop the research side of the mission of the medical school as well as the teaching and the service. So the lab was the first thing, and this, of course, very rapidly began to pay off as we turned our attention to a form of vascular and cardiac surgery as our first endeavor, moving rapidly from there into the study of arterial grafting and homografting of arteries, which led to early clinical application of that modality, and then subsequently to the study of hypothermia.
Were you aware of the people specifically at the Brigham, or as it turned out, Dr. Lewis was working in the field of hypothermia, or how did you get interested in this field?
Well, I was, of course, aware of the work going on in Boston, and Dr. Gross had been using stored homographs to repair coarctation of the aorta when there was a very long segment. And therefore, we got interested in that phase, the idea of homografting arteries, and of course this subsequently became of very great importance in cardiac surgery, with the homografting of that portion of the aorta which contained valves. And there's still of tremendous importance in the use of grafts, living grafts for coronary artery disease. But the stimulus to me to enter hypothermia was a paper given by Dr. Wilfred Bigelow of the American Surgical Association at the Greenbrier Hotel, and I believe that the date was about April or May of 1950. And Dr. Bigelow described a series of dogs in whom he had lowered their body temperature by surface immersion in ice water, after having anesthetized the dogs. And he lowered their body temperature to about 24, 25 degrees, as I recall. And he then opened the chest and simply clamped the genitalia, thus occluding blood flow to the heart, for 15 minutes. And then he reported that his mortality rate under that experience had been 85%, and that ventricular fibrillation had been the chief cause of death. And so, in the midst of that meeting, this paper caused not much concern or interest. But in flying home in my own Navion, I got to thinking over that report, and I suddenly got what I thought was the message of this paper, which was that 15% of the dogs had lived, and that these were animals who had had the blood flow, inflow of their heart occluded, and therefore the outflow had been stopped for 15 minutes, and therefore they were still alive. And I thought if one could understand this modality better and prevent those deaths, that this was a golden opportunity to enter heart surgery, because in 15 minutes of open heart time, one could obviously have attained a large number of operative procedures. One could develop operative procedures successful within a limitation of time. So that was the precise stimulus that entered our minds and caused us to turn to work in the Halstead Laboratory to really heavy emphasis on beginning to understand the problems related to deep body temperature and deep body hypothermia. That was in approximately June of 1950. By the end of 1952, in a year and a half period, over 380 or 90 dogs had been cooled, and our understanding of the risks of hypothermia had improved greatly, and our capacity to prevent the dreaded complication of ventricular fibrillation had gotten to a point that we felt it justifiable to enter the clinical arena. We were not aware of the work of Dr. Lewis until late in the summer and fall of 1952. And we knew that he was also working on the same problem. And to his great credit, must do the honor of having done the first successful open heart operation. I believe it was about late October or November 1952. Dr. Bailey in Philadelphia had also heard the paper of Dr. Bigelow and had started to use hypothermia clinically. But unfortunately, Dr. Bailey's series was short and was not successful. We did our first case under hypothermia in January of 1953. Our first open repair of the pulmonic valve in February of 1953. And by June, we could report a series of 13 cases of open heart repair of congenital heart disease with a mortality of just one patient. And I really believe that this report, which appeared rather quickly, I believe in August of that same year, in the Journal of the American Medical Association, which was in essence the first successful series of open heart procedures, which caused, I'm sure was partially responsible, served as a stimulus for interest throughout the country and indeed throughout the world for pursuing this modality for that purpose.
Dr. Swan, those are just exactly the sort of thoughts that we wanted to hear. And Dr. Pomerantz and Dr. Southern, I have the privilege of sort of having seen this from afar. It's in a much broader perspective, perhaps, than some of the modern-day graduates. What we'd also like to hear from you is some description of how you felt when you first approached the first clinical application of your laboratory work, namely the first open heart surgery. From the standpoint of, did you feel pressured by the time? What precautions did you have available for unforeseen problems, things of this sort?
Yes, yes, I can remember our first application of clinical hypothermia very vividly. We had achieved in the laboratory, and I think, if I may, I'd like to enlarge on that point just for a moment, because I believe that cardiac surgery was the only form of human surgery which was applied after an extensive laboratory experience and based on laboratory experience. Gastrointestinal surgery, thoracic surgery, neurosurgery, and urologic surgery, all specialties in surgery, had been first tried out in man, and the lessons to be learned. I remember when I was an intern, the mortality rate for resection of lobectomy and thoracic surgery was 15%. So when heart surgery was first begun, we had behind us these almost 400 dogs, as far as our experience with hypothermia, and many of those dogs had undergone cardiac procedures, opening the aorta, cutting holes between the aortals, opening the ventricle, closing it up, giving us operative and technical experience in just managing the heart. So that the first, for example, in the first 69 patients who had open heart operation on the pulmonary valve, there were no deaths, beginning from case 1. So that I think I want to use this as an example of how it would have been desirable for all the branches of surgery in the past to have a laboratory background before they began. I wasn't terribly worried about the hypothermia itself in the application of this modality to our first cases. The worry was the ability to get in and out of the heart and have control of the openings that you made, because it was clear that you weren't going to have time to sew up openings within the time limits of the open heart. And therefore we had to begin to develop non-crushing clamps that were secure and wouldn't slip off, and which would stay on even if we had to do resuscitative procedures if ventricular fibrillation had occurred, with the incision still made in the pulmonary artery or in the aorta. And you had to apply electric shock and massage and more electric shock and manual compression of the heart. So we had this technical problem of developing clamps, and there were no clamps in those days designed for the purpose of staying on a portion of the heart without injuring it. So that was part of the worry of the early patients. However, our laboratory, we have been able to take certain defensive measures such as hyperventilation and the use of prostigmine, the use of intravenous glucose, to diminish the incidence of ventricular fibrillation in the dog. And my only basic concern was that if I applied these same measures in man, it would also prevent fibrillation in man. And as it turned out, it did. Fibrillation was not a major problem, really at any time throughout my experience with hypothermia.
I need to mention at this point a couple of points perhaps Dr. Swan won't mention himself. One is, a lot of us are aware that the bathtub that was used for hypothermia at the University of Colorado has been presented to the Smithsonian Institute. And another point is that when Dr. Swan mentioned flying his own Navion, most people around the world at that time knew of his accomplishments as a pilot, primarily as a plane crasher. And I can recall during the days of his operating on open heart patients at the University of Colorado when he had his own wheelchair rigged up to a hoist that would put him up to the operating table.
Now, I'd like to straighten the record there, because it is true that on occasion the mountains and I happen to be on a collision course. But Dr. Rayner, I'd like to point out also a trip in a single-engine aircraft around the entire continent of South America. I believe I was the fourth individual ever to do that, all the way around Alaska to Newfoundland. And without any particular inclusion of these major disasters.
we wondered if the plane had been well enough preserved so that it could be in the Smithsonian alongside the bathtub.
Yes, the third airplane is still well preserved.
Dr. Swan, as a surgeon, I'm sure we'll be all interested in knowing, in case you ever got in on a patient with the incorrect diagnosis, that being a remote possibility with the cardiologist that we're working with. And number two, were you ever tempted to go beyond what you knew or thought you could do with hypothermic technique?
Well, I think Dr. Sadler, I was very fortunate because our first several years of experience with open heart surgery was indeed a team venture, and Dr. S. Gilbert Brown was associated with me, and he was an extremely acute diagnostician, and I can honestly say that it was a very rare event indeed in which I operated on a patient in whom his precise prediction was not verified. Now, this included such interesting complications, complexities of diagnosis as between, let's say, atrial secundum defect versus supremum defect, the presence or absence of aberrant pulmonary veins. Now, this falls in the second category of your question. There were several times early in our experience when I did indeed find aberrant pulmonary veins which were not known to exist preoperatively. We developed various techniques, and finally a successful technique for coping with that particular problem. But on one occasion, we simply had to ligate the vein and accept the congestion of the lung, which followed. Later on, after we were doing aortic valvular surgery, the distinction between subvalvular and valvular stenosis was not always diagnosable preoperatively. And on two occasions, I got trapped into the effort of trying to relieve subvalvular fibrous stenosis through an aortotomy above the valve, which gave inadequate exposure, and with a resultant injury of the mitral valve. But except for these very rare instances, I was blessed with a very accurate diagnostic background. Now, this is a very important point, though, because one of the things that held back the use of hypothermia worldwide as a modality for open heart surgery was the very worry that the surgeon had, and he must have based this worry on experience. He was in there too frequently and finding himself operating on a patient in whom he should not be there. So it is true that one of the criteria for the use of hypothermia as a modality for open heart surgery is accurate diagnosis.
But Dr. Swan, I'd like to ask you a series of questions. First of all, approximately how many cases of open heart surgery did you perform under hypothermia, and what was your operative mortality?
Well, Dr. Pomerantz, I can't give precise numbers to that question, but I can indicate to you that I had personally operated on over 800 by the time I retired from the surgical department at the University of Colorado. But I recall this in 1955, the International Society of Surgery met in Copenhagen, and I was asked to give a discussion of mortality and surgery and hypothermia. And in discussing that question, I quoted our statistics as they existed approximately 3 years after we began. And I recall that those numbers were that we had operated somewhere between 380 and 400 cases at that time, with an overall mortality rate. I believe it was about 12%, but in the last 100 cases, it was less than 6%. And these were all open heart cases.
But also, next, I'd like to ask you, what do you mean by hypothermia? You changed your what you meant by hypothermia. Could you just fill us in a little bit on that?
Yes, when we first began, we were not highly sensitized to the fact that in our superficial or surface cooling technique, there would be a rather extensive slide in temperature after we removed the patient from the ice bath. And the net result was that in the first several cases, let's say 15 or 20, we found ourselves with a rectal probe recording temperatures of the order of 23 to 26 degrees, which was colder than our laboratory experience and which was in the range of temperature which in the laboratory was dangerous to our experimental animals. Fortunately, not a single one of those early patients suffered any known bad effect from having been cooled to a temperature which I later considered too cold to be perfectly safe. Later on, then, we adopted the temperature of 30 degrees centigrade, a rectal temperature, as being the objective of cooling, and we insisted that the patient be hyperventilated to a continuous alkali pH, that the patient have glucose running intravenously, and that when the heart was to be stopped, a slight myocardial depressant, we used it, a prostigmine, was injected. We felt that with this technique, the open heart period of 8 minutes would be almost surely safe, that 6 minutes was totally 100% safe as far as brain damage was concerned, and that on multiple occlusions of the heart, one could obtain up to 15 minutes of open heart operating time. At 30 degrees with these various precautions, the risk of hypothermia we felt was approximately the same as that of ET anesthesia.
Let me end my questions by asking you, in this early pioneering work, are there any, how have you kept up with these families, and are there any particular children or families whose development has particularly stuck in your mind?
Oh, yes. Yes, I've kept up with many of the patients. I used this little trick. When they left the hospital and the operation was still very fresh in their mind, I asked them would they consider that operative date, remember the date they operated on, and consider it an anniversary date for them. And on that anniversary, would they please write me a letter from wherever they were and tell me how they were doing. And it's amazing how many of them did just that. For example, one of the very first patients that I operated on under hypothermia for atrial septal defect was a young lady named Clarabelle Presley. She came from Indianapolis. This was in about March of 1953. And when she came to my office, she was so out of breath that she had to walk very slowly just across my office, and I would approach my desk to sit down to me a bit. She had a giant atrial septal defect, a higher pulmonary vascular resistance than we would like to operate on today. But I hear from Clarabelle every year since then. She's had several children, and is getting along fine. So she's just an example of many patients in that way.
Dr. Swan, why don't you tell us your thoughts about what you think about the role of hypothermia 20 years after your original experience then?
Well, like I said, that's an interesting question because, of course, hypothermia having been used extensively for open heart surgery and for some other clinical purposes, such as transplantation of organs, and then the use of post-injury to the brain to prevent brain damage. Nonetheless, in general, it has more or less fallen from grace in the medical community, and I don't think it's extensively used anywhere in the world now, with the exception of a few cardiac surgery groups, which are beginning to return to the use of hypothermia and using much colder temperatures for very young children who can tolerate such temperatures well. And at the present time, this is its most current use. It's small in scope. However, you have asked a question which has been a matter of great interest to me. And I recently have reviewed the history of clinical hypothermia throughout the course of man's existence in the world. It turns out that hypothermia over many centuries has waxed and waned in the minds of doctors in cyclic manner. Now, my own opinion is that we have to recognize that hypothermia, which I define as a body temperature lower than is normal for a homeothermic animal. It occurs naturally, and when it does occur naturally, it's extremely dangerous and has a high mortality rate. Mountain climbers and elderly individuals in nursing homes who get significantly hypothermic in great danger of their life. Another form of hypothermia that we discussed here today, though, is that which has been applied deliberately by one individual on another. And this, therefore, offers the opportunity for control of multiple variables in the experience. And I feel confident that there is a promise of potential in clinical medicine in a variety of diseases, which as yet have been essentially unexplored. Unfortunately, the use of hypothermia requires a very considerable basic knowledge and experience in biochemistry, bioenergetics, and physiology. And therefore, I think in the future will have to be more of a team endeavor involving basic science-oriented personnel as well as this physician. It's unlikely that practicing doctors will be able to achieve this kind of overall knowledge to manage hypothermia well. So it remains a problem. I call it, in my review, the history of a lady with a past and a potential for the future.
Dr. Swan, thank you again for this interview this afternoon. It's been exciting for us, and it's been particularly exciting for Dr. Pomerantz, Dr. Sadler, and myself to begin this series that we've been thinking of and planning for so long. Thank you.